Okay, thanks, Jocelyn. Because we only have 15 minutes, I'll dive straight in. But I'm going to talk about an intervention called experience-based co-design that I've been involved with developing over the last 5 or 6 years or so. Experience-based co-design, just some of the key features. It's a real partnership between patients, staff and carers. An emphasis on experience, that third element of the definition of quality that we were hearing about in the last session. We use filmed, narrative-based approach to identify something called touch points, and I'll give you some examples of that in a moment. The emphasis is very much on co-design, and this is the bit of the approach that I'm going to focus on in this seminar, given the theme. And it's also around systematically capturing the improvements and benefits that result from implementing experience-based co-design. Just to say that there are various sort of toolkits for the approach that are available. The most recent one developed by the Point of Care programme that Jocelyn heads up at the King's Fund. The NHS Institute for Innovation and Improvement, who funded the original pilot work, also have a toolkit, and there's various other toolkits popping up on the web all over the place. The final one here is from New Zealand. So just to give you a quick overview of the experience-based co-design process, it is a design process, 6 stages. The first stage, there's the setting up, core group, advisory group, including patients, carers and staff. The second stage is around engaging staff in the process and gathering their experiences through interviews and observation, then having a feedback session with them where they identify what they feel are the priorities for improving the service. The third stage, similarly, but this time with patients and carers, and this is where we use the filmed narratives, capturing patients and carers talking about their stories, their experiences, bringing them together as a group, just the patients and carers, to share each other's experiences, watch each other's films, go through a number of facilitated exercises. I'll show you some examples of those in just a moment. And again, for the patients and carers to come up with their priorities for improving a particular service. Stage 4, then bringing the patients and the staff together for the first time. The staff get to see the patient films, they get to meet with the patients and carers, and again through some facilitated exercises, then coming up with their shared priorities for improving the service. Stage 5, the patients, carers and staff break off into smaller, what we call co-design teams, where they work on particular aspects of the service that they've agreed need improving. And then stage 6, coming back together, celebrating their achievements, reviewing what's happened, and then renewing the process. So this is a cycle. This isn't a time-limited project. This is a continuing cycle of design and improvement. I just wanted to give you a sense of what it's like to take part in one of these projects, and I thought the quickest way to do this was just to show you this brief film clip. This is actually from the very first pilot that we did of experience-based co-design. This was in a head and neck cancer service in Luton and Dunstable. And you'll see here some of the staff and patients and carers who took part in that project, just talking about what it was like to participate.
And it is new. I've not come across it before, where we've actually involved the patients in that way of improving services for them. But I think it's definitely a positive thing having all this work going on.
My own view is that this is an organisational philosophy. It's about an approach, and the partnership between patients and staff should be a principle behind every improvement project.
But I've been very pleased with the amount of involvement that we've had and how collaborative the whole experience has been.
I've had the surgery, I've had the treatment, but I'm not forgotten, It's like belonging to society.
I've been really impressed to witness the patients in the same room as the professionals delivering care, and seeing the interface with them in a completely different light. Just seeing them talk to them as normal human beings, not as the paternalistic doctor-patient relationship. And I think there will be tremendous dividends from that for the whole health service.
And I can't get over the fact that the staff didn't need to become defensive about anything. The consultants turned up, and the charge nurses, and the people from reception and the patients, and we were all together, and there was that terrific sense of it's an equal playing field. Anybody could speak. There was no sense of fear. There was no hanging on status or using it. It was quite incredible, really.
Been very pleased to work with it. I'm quite happy to continue working with it.
I think it's actually been is a very powerful, more than an exercise, it's almost like a movement.
The collaboration movement.
I think it's given us the opportunity to hear what patients really think about the way we're delivering services, and it's given us the opportunity to do something about it.
Okay, so I hope that just gives you a quick sense of what it's like to take part in one of these projects. The origins of the approach explicitly come from design and the design sciences. So how do architects, software engineers, graphic designers think about designing a new service or a product or a process? And I think there are 3 contributions that the design sciences have made to the way this approach has developed. The first is in terms of a way of thinking about change, a frame of mind. So the design sciences are very pragmatic. It's around making sense and finding solutions to a particular challenge or a particular problem. There's also specific methods, tools and techniques that we've taken from the design sciences, so lots of emphasis there around modelling, about prototyping, about trying things out, again in a very pragmatic way. But also there's a design process, a sequence of activities of moving from the blank sheet of paper to first design, trying it out, second design, etc., etc. So I think there are various ways in which design and the design sciences have contributed. And two particular ones I just wanted to highlight as distinctive features of design theory are around direct user and provider participation in a very face-to-face collaborative venture to co-design services. That's certainly a feature of what we try to do with experience-based co-design. And a focus on designing experiences as opposed to just systems or processes. And we heard some of this in the last talk around the 3 domains of quality that is now the accepted NHS definition of quality. And it's very similar to the way in which designers talk about the way they design services. So if you want to think about any good, well-performing service, it has to have 3 attributes from a design science perspective. First of all, it needs to do the job that it's supposed to do. It needs to be fit for purpose. It also needs to be safe. It needs to be well-engineered and reliable. And then thirdly, it needs to be how the whole interaction with the product or service is actually experienced. And typically what we've done in the NHS is we've concentrated on the first 2. So we do a lot around performance, functionality, efficiency. So lean, no delays, all of the productive ward work is all focused in that kind of performance efficiency domain. We obviously do a lot around patient safety, around the engineering domain. But the argument here is that we haven't been doing enough around the third, around the aesthetics of experience, and it's that experience-based co-design tries to help with. It's not saying the first 2 aren't important, of course they are, but we need to remember the third as well. So from a design perspective, what should we be thinking about doing around quality improvement in the NHS? Well, firstly, that point I've just made, it must obviously fulfil the core task and be safe, the functionality and performance domains. But it must also appeal at the emotional and sensory level, and that patients and carers need to be active rather than passive, using their specialist form of knowledge, in this case experience. So how do we get at that experience part of experience-based co-design? The first bullet point is a topic for another seminar, really. I don't think it's for via patient or staff surveys. I'm always very happy to talk about what I consider to be the limitations of those for local quality improvement work. But the way in which we do it in experience-based co-design is through deep dives, ethnographic methods, direct observation, and also through patient and staff stories. And I'm not going to have much time to show you examples of the value of these types of approaches. This is from some of the observational work we did in an emergency department in Sydney, in a hospital in Sydney. This is the reception at that emergency department. This is a visualization of the patient experience. But the important thing is, this is what it's like for the staff experiencing that check-in in that same emergency department. And there are lots of fantastic examples from various experience-based co-design projects of the real power of observation, of just hanging around and seeing what goes on a day-to-day basis around processes. And when you feed those back to staff, the kind of reactions you can get to those things that you've observed. So what do we do once we've done this observation and we've collected all of these stories? What we're looking for are what we call touch points. These are the really big moments that have shaped an overall experience for a patient. So to give you some examples from the Head and Neck Cancer Project, classic touch points are the breaking of the bad news moment. So obviously when the patient is diagnosed with cancer. The PEG moment, these are the feeding tubes that lots of the patients have to have after they've had radiotherapy. Often the staff are very surprised by this one because they see this one as being quite a trivial procedure in the whole experience. Lots of these patients have had traumatic surgery, they've then had radiotherapy. But the patients would talk about this in terms of this was when the cancer was made visible and of being the last straw, and this was a real touch point for them. The waking up moment in ICU after surgery. The mirror moment, this is when the patient sees themselves for the first time in the mirror after they've had surgery. They're always supposed to be accompanied when that happens, but we'd often hear from the patient stories that they'd be alone, they'd wander into the toilets on the ward or the bathroom, they'd see themselves for the first time. And then the radiotherapy and the radiotherapy planning moment. And I've just got a short clip just to illustrate this type of touch point.
So when I was called in, there was a nurse who I didn't see immediately, a female nurse. But the person I saw, somebody called Adam, I'm sure he won't mind me mentioning his name, having said hello, and his name was Adam, said, right, strip to the waist. And I was absolutely dumbfounded because I simply didn't expect that this was anything to do with an examination or whatever.
As far as Mount Vernon is concerned, I didn't get much information. I met a friend who warned me. Little issues. She said, they will ask you to strip to the waist. So I was prepared for that. But there was another gentleman in the room, a professional man. I'm quite used to that. But they don't say, would you get undressed? They say, strip to the waist. And I found that a bit... and I looked across to Adam, and he said, well, it's all right, we're quite used to it. And I said, yes, I'm sure you are, but I'm not. So they give you a piece of paper to cover yourself, but it slips and slides.
And I can remember the nurse when I was on the couch, trying to pass me some very stiff paper to put over the top of me. And of course it wouldn't stay on anyway. And looking back, it was probably quite amusing, but at the time it wasn't really. And I know that somebody else actually said something to Adam, and he said, well, I'm so used to it. But of course he is, but we aren't. So he probably has the message, and later on I did meet him again several times, and you couldn't meet a nicer person.
Okay, so a nice example of the radiotherapy planning touchpoint moment. Patients thinking they're going to a meeting because it's called radiotherapy planning, and then walking in and being asked to strip to the waist. Something that's stuck in the mind of particularly these two patients. So having collected all these stories and identified these types of touch points, what we do is we then bring the patients and carers together, they watch each other's films, and we take them through a series of exercises which are really just about getting them to reflect together as a group on their experiences and then decide what are the priorities they'd like to work on with the staff to improve that service. I'm pushed for time, so I'm not going to show you too much of the exercises, but I'll just give you some of the examples. So we start off doing something we call experience mapping, again coming very much from the design sciences field. This is where patients and carers, not staff, do the mapping. So this isn't traditional kind of process mapping that you'd see typically in the NHS. It uses a wide range of low-tech tools and techniques, focuses on experience rather than formal, idealised system steps. The focus is on those critical touch points. And the idea is to build a model of design rather than an abstract system of care. So the type of thing we do is, along the top here, you'll see in the yellow boxes are the traditional stages in a patient's journey, so going to the GP, being diagnosed with something wrong, etc., visiting the outpatient clinic. Then along the middle, you'll see lots of white bits of paper. Those are the touch points that have come out of the patient's stories. And then we have a simple high-low scale on the far side. And we just take the patients through an exercise where they go up individually and talk as a group about which of those touch points, where do they go on the high-low scale? Are those very positive touch points? Are those negative touch points? And what you end up with is this sort of emotional roller coaster of the touch points, about the high and low touch points across the whole of the patient journey. And then what we do is, having got that map, we ask the patients to think about the emotions that they felt at each of those particular touch points. And this is always recognising there are some emotions that we cannot and would not want to do anything about. They're just a natural human reaction to having a diagnosis and being treated for cancer. There are some emotions that are positive and we want to keep, amplify and enhance, but there are also some emotions that we feel compelled to do something about. So again, we take the patients through an exercise of using the emotion words that have come out of their interviews, of their films, stories, and asking them just to add those emotions to the various touch points that they've put up on the wall. So you get a sense of one patient saying they were lost around their spiritual needs, a whole range of emotions around that first meeting with the consultant. And we make sure there's lots of blank bits of paper so that patients can add new emotions and touch points in during these exercises. Julie on reception making one of the patients feel happy. So at that point, the patients and carers then begin to think about what are their priorities for improving the service, and they take those to the staff at this fourth stage, the co-design group, where they meet for the first time, the staff see the patient films, and they agree the priorities that they're going to work on. So this is the co-design bit, which is the really important bit. I think there's quite a lot of experience-based work going on in the NHS, but I think it's the co-design bit that really brings the value to this process. So we have a number of options. We could not listen to our users at all and just we as staff managers go off and do the designing of services. We could do all that experience-based work, capture the stories, get lots of feedback, and then we, the staff managers, just go off and do the designing. Or we can listen to our patients' carers and then work very closely with them in a co-design way to improve services. And it's obviously the third that we're looking at here. Am I pushed for time? I was going to show a clip of some of the co-design meetings just to give you a sense of what they tend to go. I'll skip over that. This is an example from this original head and neck cancer pilot where one of the co-design teams said they wanted to talk about and work on improving the physical environment of the outpatient clinic for this head and neck cancer service. I'll just include this because I think the quote is quite nice. You'll see here some of the pictures of patients sitting behind the desk to see what it's like for the receptionist. If you'd been able to see the film, you'd have seen the patients and staff carrying the furniture around and completely reconfiguring the outpatient clinic. But the quote was quite nice because it was quite funny to see them lifting up their chairs. I think that becomes a symbol of the project. It's a symbol of the project that those chairs are those patient seats, and it's about the staff and the patients together just moving everything around, so it becomes the symbol for the whole project. I'll very quickly wrap up. I was just going to say a few things about evaluation and about the impact of this approach. Jocelyn's team at the point of care at the King's Fund have done an evaluation of a recent implementation across breast and lung cancer services in 2 London teaching hospitals, and you can download that from the point of care website. The work in Australia in 7 emergency departments has been evaluated by a team from the University of Technology Sydney, and again that's available and the references are there. I think the important point here for me is the second one around that they found that these processes were qualitatively different from conventional consultation and feedback. There's lots of implementations of EBCD going on in the NHS, some of it led by the NHS Institute, various projects I'm involved with, and I think it's influencing approaches elsewhere. And there's various places you can go for more information.
Thanks, Glenn.
Sorry, bit of a rush, but...
I'm sorry to rush you, but I think that what Jeremy is going to say is going to kind of build very much on it, so hopefully we can come back to you at the end.
Okay,
yeah.
thanks.
Jeremy.